Okay, it's 4:30. I would like to, hi there, I would like to call the March meeting of the Monroe County Board of Health to order and thank everybody for coming. We have a lot of people in the room. We have several people online joining us. Welcome, everybody. Before we get started, I just want to remind all board members that this is, of course, being taped and we're being videoed, and it will live on the internet forever. So just keep that in mind, sharing your, because the internet never goes away. So there's the call to order. The first order of business, the approval of previous meeting minutes.
I would move that we approve the minutes as written unless Kay has some corrections.
Is there a second? And is there a second? And then we'll hear from Kay about the corrections.
Kay isn't correct.
Thank you.
Kay will-
There.
I will.
Oh, okay. I
will
think Dr.
second that
McKinley
motion.
seconded it, but all those in favor of accepting the February minutes as written?
Aye.
Aye.
Okay. Public, boy, a lot of chiming here. Public comment. Do we have any members of the public that would like to comment on anything?
It's not on the agenda.
Pardon?
That is not on the agenda.
That is not on the, well,
Public comment is on the agenda.
No, the public items that are not on the agenda.
did you say that? Okay. We have a member of the public. The time limit is 3 minutes. Would you please introduce yourself?
My name is Melanie Davis. I apologize for my voice. I had surgery and it's kind of messed up the other day. I had a friend come in earlier, I guess a week ago, who had a coworker to change her daughter's name and birth gender on her birth certificate. And that was denied. And we've gone through a lot. They're actually trying to seek legal counsel through the ACLU. I understand this has been something that was handed down from the state. So it's not just Monroe County, but actually, I mean, I can't ask questions, but I would like some clarification on who handed this down, where this came from, where we can find more information on this, because this is, I understand it's in respect to the executive orders from Governor Bond. However, it's going to affect a lot of people, including people who, like myself, who are members of the intersex community. I didn't find out until I was an adult. I'm also transgender because I was raised as male. But people who are intersex also will be impacted by this. And there's no clarity. There's nothing that's been put out for the public. There's been nothing that would help people navigate this and also find redress.
Thank you. Do you have maybe 15 or 20 minutes to stick around, because that is an agenda item for us, and I think all of your questions will be answered if you would like to stay here.
Yeah.
Thank you. Any other public comment? Okay, moving on. We are going to make a ton of changes to the order of the agenda because we have several speakers here with us who I'm sure would like to go home and have dinner rather than stay here and hear our boring discussion of contracts to approve. So what we're going to do is move one item from department updates, which is number 2, vital records, to address Melanie's question. We're also going to move under new business numbers 1, 2, and 4, because we have speakers to speak about that. Any questions, comments, concerns? Right, should we dive right into Kathy and let her go?
Sure.
Okay.
And I've been working with Dave this week, so I don't know if he has something to present.
Lori has something, so maybe we should start with Lori and then you could chime in. Is that okay?
Absolutely.
Okay.
So, guidance in the past that we have received historically is that the Indiana Department of Health is the organization that makes gender changes. So when individuals present to the health department, we do have access to go in and make name changes. The process then goes to submitting a ticket to the Indiana Department of Health to have a gender change made. What we received from the Indiana Department of Health on March 14th was that they will no longer process gender change requests. And so that's kind of the situation I think we've been dealing with now.
So if it's counties between a rock and a hard place, if they have a parent come in with a court order saying to change the gender, yet IDOH is saying, don't change the gender.
IDOH actually is the one who goes in and makes that change.
Okay.
And we have been instructed that we cannot make that change, that it goes through the Indiana Department of Health.
So you have something that Dave worked up for us, or
Yes.
it looks extremely legal, which is why I'm looking at Dave.
Yes, so currently, Kathy and I did meet with Dave and we discussed our internal processes. So what we are doing is case by case. We are taking the court order that we received and we will be submitting that to the court in Indianapolis. Am I speaking on that correctly, Dave?
Well, I guess the proposal is, and I have a draft document, if you want to, if you'd like copies of it, you can review that, but basically, just to report to the court that we've complied with the order to the extent possible. And see what happens.
So we are able, forgive my ignorance of how the data system works, but we in Vital Records, we can request some change be made, but we can't actually make the change. Is that a good way to say it or no?
The state has always mandated local health departments not do gender changes. They will never tell us why, but they said we can do the name change, but we have to put in a request for them to do the gender change. So following that instruction, last week, with what I assume was your friend, they told us they were not going to do them anymore, citing the governor's order. And I am holding a court order instructing anyone issuing an identity document to change the gender, and they wouldn't do it. They have told us we're not allowed to do it. So,
Okay, so
That's where we
we're
are.
between a rock and a hard place.
yeah.
Their documentation can be the same from the state that we can look on to say who has made this decision.
Yeah, those documents are attached to this proposed report. I have 9 copies, if you want to see it.
Oh, you made copies?
Yeah.
Oh, aren't you wonderful?
Well, I'm only 9 copies, so people will have to share if they want, but if the board approves that, we can look into filing that. These cases are confidential, and so we can't get to it from my case. So we would have to find a way to file probably an appearance and a motion to intervene for the limited purpose of filing a report to the court and then see what happens. I feel like calling the judge speak up who's traveling this week to see what process that she might suggest. And she said she would come in on Monday.
So you would like us to vote on this?
Well, yeah, if
Okay. And because we haven't read it.
Yeah.
Because we just got it. We're all speed reading. Lori, can you tell us what it says, or Dave, what?
Yeah, basically, it just sets forth all the statutory requirements relating to the creation of birth records and the role of the health department in it. So the court's order is basically saying we're directing anybody that has issues identity records, including the State Board of Health and its subsidiaries. So we're establishing that we're a subsidiary, talks about the process that we go through. And then it talks about the state requirements for maintaining birth records on the Indiana birth record system. And it notes that we also have our own birth records system for people born up to 2006. And that's under the county control. So what the county is doing, and then after that, it's the state the state has been maintaining records on the Indiana birth record system. So what this report is basically saying is when we get an order from the court, we change the name and the gender marker on our local system. We have the authority to change the name on the state system, but not the gender marker. So then we send it up to the state. We used to send it up with a ticket. Then they've let us know that they're not even processing those tickets until they hear from the Attorney General. So we just send copies of the order to the State Board of Health, their vital records response team or whatever it's called. And it just lets the court know that's what we're doing. And if a record comes in that, is 2006 before, we'll change it on ours. If not, then we send it to the state.
So we will, I just want to be super clear for everybody before we have a discussion. So we will change gender on a record that we have control over, which means 2006 and older.
I think that's what we've been doing.
Okay.
And,
And we don't have control of anything newer, like 2007 on. So we are unable to change that.
we can only change the name
Okay,
because the state has authorized us to do that.
okay,
It only applies to gender. So we have attached to that document, we have the Governor Braun's executive
this
order.
is great, thank you, this is
And
really helpful.
we have the ticket form that is used in the guidance from the state that came out in about 2022, 2023 regarding gender orders. And then we have, and that guidance says basically the order has to say, be clear enough that the State Board of Health or the State Department of Health will change the gender. So it makes it clear that that's their responsibility in their eyes. And then we have the Exhibit C attached to there, which is the email from the Vital Records Director saying, we're not processing these until we hear from the Attorney General.
Thank you very much. And Kathy, are all your folks in Vital Records informed about this, aware? Okay, yeah. So everybody's going to be given the same message, I guess.
Absolutely.
Okay. Good. Does the board have questions? Is there discussion?
No, it's just unfortunate that it came to us as one of the initial things following with a court order shortly after this executive order. So you can understand how
We were kind of
confusion
blindsided.
it was taking place.
Yeah,
Not making any excuses, but we're kind of learning with everyone else right now. So
The state did not tell us until Friday afternoon, when, again, what I assume was your friend, because there was only one person that came in that we couldn't help. And I had to call up there and they told me they wouldn't do it. And I had to go, and unfortunately it was one of those not in our local systems.
and it always happens on Friday afternoon.
Yeah,
Yeah.
and at shortly after is when they sent the email to us, so we didn't even know until Friday afternoon.
So the health department has sent some tickets up to the state, and the state has, under the old approach, but the state hasn't acted on them since this February email, February 14th email. So March, actually.
Any other questions or should
Can
we?
we publicize this so that other people who are in the situation know what they need to do?
That would be helpful.
I think,
People across the state.
I think it would be nice to put something on the website.
It's a major change for some people.
I think too, I've gotten word this week from the court that we could change. They came directly from the court to us. Those people don't know that we changed them. I don't know if they're aware or if they got them knowing about this order. I wish there was a way we could communicate to them that we made the change and they can come get their birth certificate. Because I think some people are just going out now and trying to beat this. And they may not know that it's been done. They may think it can't be done.
So should we, what other, besides social media, which, you know, again, I have to say, all hail to you. Your social media presence is so amazing. I love what you've done. Every single time I see something on my feed, I'm just blown away. Thank you. But besides social media, besides putting it on our website, how else should we publicize this so that the general public knows?
So is there any kind of a requirement for publishing changes in the law in a local newspaper like you do for land exchange changes?
Not for something like this.
Not for,
No, we have some publication requirements. They're mostly around funding and employment.
Oh, it's clear that Dave sitting here will also be passing it along. to
So we perhaps have a
members of the
journalist.
community.
Yes.
And,
I'm, so you go ahead, Sarah.
well, you know,
I just wanted to say that I'm happy to report what happens at this meeting. That's what I'm here for.
mhm.
It's not totally clear to me yet what people should do. So I've heard people say, we need to publicize this so that people know what to do. And my conclusion, based on what's been presented so far, is that, well, you're out of luck. But I'm not so sure that that's exactly right. So I'm speaking now to say I have great unclarity in my mind about
Okay.
what I could write as a fact.
So could we ask, does this make sense? Since you, pardon the pointing, and you are really the experts here, could we ask you to craft a very easy bullet pointed public message saying, do this, do this, do this? That's what we publicize so that people will know
we could reference the governor's executive
steps
order
to
so that
take.
people can think about it themselves.
Yeah, it's really a private matter. It involves the parties and the government. Because they would be the ones that would have standing issue a suit against them.
Well, I just wouldn't want parents coming in trying to change birth certificates and then getting upset with staff. I mean, I'd like us to
Yeah.
have a public statement that they could say, here are our steps, here's what we can do, here's what you can do, here's what we can't do.
Or it's like, I don't know if there's a public comment question. I was trying to keep my thoughts to myself. I'm David Henry, County Councilor. Thank you for Dave asking the question on my mind, but I'll ask it in a different way. So if staff is presented with a person, are you able to hit save and create the ticket? Or does it not even let you save locally the data entry to create the ticket that goes to the state?
If someone comes in with a court order?
Yeah.
Court, well, first of all, if they were born prior to 2007, we could do it.
We change
Yeah.
it, yeah.
So, and those are most of the ones we get.
Yeah.
We do get some that are younger or a parent comes in, but most of the ones we get are older than that, and we can do that.
So if someone under, are you able to actually complete the computer activity? Can you save the activity and create the ticket and then it just goes to Indy, or does it stop you right here? You can't complete the ticket.
We would go into the state system, do the name change if there is one, create a ticket that goes to Indy requesting the gender change. And it pretty much sits there.
So our county's done its job to
Yeah.
do it
And
anyway.
that's what Dave
And that's
said.
really what the direction is, that we'll do our job.
We'll do our
That's what
job.
Shelley Davis said, right?
Yeah.
We can at least get as far as creating the ticket.
Yeah.
So you're not turning anyone away here. Okay, I think I have a little more clarity for how the process would work.
So I think that's basically, thank you for asking the question. I think that's what people in general would find helpful if we could publicize that, or that they know if it's child was born prior to 2007, they can come on in, we'll do that. And we'll make the request to the state if the child was born 2007 and after, but they may need to seek legal help, right? I wonder if, Steve, am I allowed to recognize a person sitting in the gallery who raised their hand on this topic? And
Oh, yeah, I think so.
yeah, you think I can do
Yeah,
it?
but I think it's your discretion.
Yes, would you like to ask a question or make a comment?
Yes, I had two questions, and I am Jody Madeira, County Commissioner, brand new County Commissioner, so learning along with everybody else. What's a child? Is a child 21 and under, or is a child 18 and under? And so that would maybe be a question for Dave. And my guess is that it might also be very helpful just to reinforce that for people who are adults, these changes can still take place. So if you were born in 2000 or 1990, these changes can still take place, because I think there are places in the state where they are not taking place.
I bet you're right.
Yeah.
Thank you
Thanks,
very
open
much.
up the night.
Thank you very much. So that
Thank
statement
you so
should,
much.
that statement should be in whatever we publicize.
And
As well.
that criteria is specific to Monroe County. Each county is gonna have
Is
its
gonna make
own
their own decision.
older system that may or may not apply to, but for us, that's our
Gotcha.
criteria.
Gotcha. Okay,
I would also,
did you have a
I
comment?
have resources that I can share for publication. Or
Okay.
Excellent.
To stream this statewide, because I know people all over are asking about this. And it's actually compared to the big being the listing of some people in Canada.
And do we have Melanie's contact information? Okay, thank you. Any further discussion? I'd love to wrap this up and get a vote.
Did we answer Commissioner Madera's question about 18 or 21?
I don't know. What's a child? Is a child,
Yeah, I don't.
what's the age when a person can come in on their own without their parent and request a birth certificate change?
What's the change? If they have a court order.
Well, no, if they're 18, can they do it on their own for their birth certificate?
You have to have a court order.
You have to have a court order.
Change.
So age doesn't matter.
I don't believe it does. The executive order doesn't have anything to do with each.
Okay, so it sounds like there's the answer.
So if a 16-year-old walked in without a parent, would that be the same procedure as a 16-year-old with a parent, or an 18-year-old or a 21-year-old?
It sounds like the trick here is a court order.
So if they were a
Gotcha.
21-year-old, we could
Gotcha.
change them under the old one.
Mhm.
Right, if they're that old, we can change them
Yeah.
under the old one.
Right, yes. And then 18 is fine, because it seems that 2007 year is correlated with the age of the child, 18 and under. So I guess that answers the question, is 18. Yes, but there's no other requirements that 16-year-olds show up with a parent if they also have a court order. That also might be helpful for people to know too.
Is there? If we had a 16-year-old come in, let's say an emancipated minor, 16-year-old comes in with their own court order, no parent.
Any court order that walks in the door, we try to comply.
Okay, it's the court order walking in the door, folks. Thank you, Dave. Thank you. Thank you, Dave. Yeah, nobody wants to ever go against a court order. That's just not good business.
And I mean, yeah, I can't tell you if there's any ramifications for changing it on our system. Because, I don't know if it's tied to grant approvals or anything like that.
It shouldn't
Yeah.
be. Thank you.
Because we don't know
Yeah,
how that's gonna be approached. So that's an issue that's out there.
okay.
But since we do have a court order and that's something that we actually can do, whether the state regards that as a lawful birth record or not, that's that's gonna have to be determined.
Thank you.
All right, thank you. Hey, does somebody make a motion?
To approve this.
Yeah,
For that,
yeah.
yes.
So we are voting on that this would be attached to their court order and sent back to the state. Is that is that what we're voting on?
This would be, the intent of this is to possibly file this with the issuing court, just to let the court know that the county has complied with its order to the extent it can.
Basically, this outlines the circumstance which we, and how we went about making our decision, really.
This, the form of this document here could be easily adapted to any word that walks in. We can just plug in the cause numbers and other things. But Lisa, the ticket, if somebody comes in with an order, we'll do the ticket process with the state and then file this, which basically says we've changed from our records and done the ticket process with the state.
Okay.
Yeah, I mean, really, we're kind of, yes, kind of endorsing this
I
document.
would move that we approve this document.
Thank you.
With the attachments.
Thank
And
you,
I'll second that.
thank you very much. Can we vote? All those in favor? Aye. Any opposed? Okay, I want to also say thank you to Monroe County for letting us change
Because you
this prior
have
to
someone,
2007.
because you have the numbers online, I think you have to do a voice. Yeah, you have to do a roll call vote. She's out. Because you have,
Even though we have a quorum in the room.
yep,
Okay,
Yeah.
we have to do a roll call vote. Diana, you're gonna have to come, you're gonna have to unmute. Are you leaving? Thank you.
No.
Okay, you're just getting your stuff.
don't need it.
Roll call vote on the motion to approve the information pertaining to gender changes on birth certificates. All those in favor?
No,
No.
go, roll call.
Roll call.
Each person.
Okay,
Lee
Lee.
McKinley, aye.
thank you. Lisa?
Nay,
Steve, yes.
Sarah?
I don't get a vote.
Oh, I'm sorry. I forgot. I forgot you don't, okay.
Yes.
Diana?
Aye.
And I vote aye. Passes. Thank you. Okay, thank you very much. All right. Next item, do you want to do I or do you want to do? No. I don't. That's right. Okay, we're gonna do new business numbers 1 and 2, meth properties and code revisions. And
I don't know how little or how much you know about the meth properties in our community, but we currently have 12 homes that
Because there are some new board members, why don't you introduce yourself?
Simeon Baker, the senior environmental general. Thanks, Steve.
Extraordinary.
And there was an opportunity to have some funding from the state, and it appears that we should be able to get funding. I'm not sure if it has to be approved by the board, but there should be information in the packet that goes over just general what we're trying to do and what our end game is here is to try to get as many of these properties tested. We have a local company who's on this list to do the testing. And we hope that it will get cleared just by initial testing. And if not, if funds are still available, to do remediation. So what different means of remediation? Usually it's cleaning.
I've got a code revision thing on here saying we need to vote on it. Did you submit some code revisions that have to do with meth properties?
So this is just separate from the code revisions. So the meth property,
Okay, so they don't go together.
It's not a code.
They're separate.
Okay,
No.
sorry.
We have several different code
Okay.
provisions.
So do we have anything we need to follow up for this?
I think that it might be nice to just vote that this is an internal program that we're gonna work to pursue to get these homes off of the list. I have received approval from, the Indiana Department of Health to pay a contractor. We do have to pay, an outside contractor to go in and do this testing, but we can go ahead and at least, initiate that process.
Questions? Simeon?
What is this test, what it costs, Simeon, to
Uh,
test the property?
It varies upon the size of the home and areas tested, but the estimate was approximately $1,000 per home to test. And then it could be anywhere from several thousand up to 6,000 or 8,000 potentially for actual remediation. So
Ridiculous, but, so is it based on square footage? That what they,
no, it's really based on the testing that has to take place in certain areas of the home.
oh, okay, got it, thanks.
So if you have 6 bedrooms compared to 2 bedrooms, then that will lower the cost per test.
Thank you.
It's pretty straightforward. We've been doing this for a number of years. Currently, if we have an active meth lab, we would have to deem the property unfit for human habitation. And we felt that since this was prior to us getting more involved with this, we were working with the homeowners. And thus far, we've not had any potential concerns for human-based health at the properties, and that would have gotten us to be more active.
So if it's a remediation, they have to do that. Homeowner does the remediation. They're up their own property,
They would hire
Okay, so
somebody
that-
to
and we charge them just for the testing.
testing and potential remediation.
And we would do that also if they hire us.
The company that's hired for testing would also do the remediation. Yes.
But the
It's a
home
local company.
does not have to remediate after you've tested, is that correct? If a property tests positive, must the homeowner remediate the property, or can they just leave it
No,
with
it
nobody habiting?
can't be occupied if
Well, it
it's
can't
not.
It already can't be occupied.
Yeah.
But if you tested it and it tests positive, does the property owner have to remediate the property, or can they just leave it still fallow?
By law, they would have to be sent an order to leave the premises within 5 to, I believe, 10 days or up to 15 days. And then it's at the discretion of, if any of the belongings need to be removed, and that's up to the actual contractor. But that area that was positive for meth would have to get cleaned and retested. That's the simplest method.
But I think Sarah's asking, do they have to do it, or can they simply walk away and say, oh, I'm not doing this, this is not my business, and then we've got a meth property sitting there with nobody cleaning it up?
Yeah, I mean, a current one, we would follow guidelines by the state law. And that is that we would send an order, that we have an active occurrence report from the meth bust, and you have to vacate the property between 5 and, I think, 10 or 15 days maximum.
But then can it,
And if they don't, then it would go through.
Yeah, I was thinking that the prosecutor was responsible for that part of it. If we declared it, if we condemned it and then had it boarded up or whatever, maybe, I think that maybe you could board it up and get away with allowing it to stay, or, if it's condemned, you can have that demolished as well. But I think the prosecutor might be responsible for actually enforcing that part of it, because that's in the criminal code.
Thank you, Dave.
Yeah, that's in the state code, yes.
Thank you.
Yeah.
Other questions or discussion? I think Lori indicated she would.
yeah, I would move that we continue to support this program as we have in the past. And I don't know what else I need to say about that, but yeah.
Do we have a second?
I second.
Okay. Those in favor?
You
Or
have
no,
to
no, no,
roll
sorry. Roll call.
And McKinley,
Aye.
Steve, aye.
Okay.
Aye.
Diana?
Aye.
I'm an aye. Thank you very much. Passed. Thank you.
Thank you.
Okay, and do we have someone here from IHI?
Yes, Julie,
Oh, we have somebody there from IHI.
yes. Which Julie? Julie Pinkins. Mhm.
So we're moving to the
There we
part
go.
about Indiana Health Information Exchange. We can hear you. Can you hear
Yeah.
us?
Yes.
Awesome. Welcome.
Okay.
So I thought having
Go ahead.
Julie, she could just give an overview of the program and then actually be able to address any questions that the board has about this program, which is why I've invited her to this meeting tonight.
Thank
Yeah.
you.
Yep. Yeah. We're the state's health information exchange, the only health information exchange in the state. We are working closely with the state for funding. So for those of you that may not be familiar with IHI, we receive electronic data from over 140 Indiana hospitals in the state, labs, specialists, imaging centers. It all flows to a data repository, and we have applications that allow approved users access to view patient-centered data for any health source that has sent us data for that person. So we get all the major health systems, Community, Ascension, IU Health, Franciscan, Eskenazi. I think we only have small gaps in the Terre Haute area up north in the Lutheran area, and then some of our border counties. So what that allows, people that access our data via our CareHub or our CDS application is the ability to view all patient data that we have for that person from these health systems in one location. So, a lot of times you're limited by even having data access to a hospital system's data, or, amongst different health systems that use different EMRs to collect that data. And so it's one stop to see lab data, medication data, demographic data, discharge summaries, any information that those facilities send us, you would have access to if you're assigned access to that patient. So I'm here today. We've been working with the state Department of Health to help our local health departments in the state of Indiana get access to patient data to assist them when they're assigned their NBS cases, for the various like outbreaks, or if it's lead or I think the STIs, things like that. Any kind of investigation that they need to gather information for and respond to. They have a grant funding available to them, the state, and they are allocating that to local health departments to help them get set up with access to IHI's CDS and PASS applications. So it allows the health departments to register these patients that they have been assigned to them in the NBS system, and then log into our CDS application and view that comprehensive longitudinal health record we have for them from all the various sources that have sent us data for that specific patient. So it allows your public health nurses to log in and view this data in one location, saves time on the phone, waiting on faxes, waiting on emails, doing that necessary follow-up, because we get this data in real time. So it allows, your nurses and staff that would need this data, the ability to get it faster and probably to gather even more information than they thought that was possible to gather. So, and view for this patient. The grant funding covers the setup with IHI and the first year of services. And then after that, the onus would be on the health department to continue paying that annual fee. There is an ability to terminate after that first year. You just have to provide a 6-month notice. So really, you can at least try it out for free for the first year. If you don't like it, or you don't find it as useful as you were hoping it to be, you could terminate within that first 6 months, and you'd still have access through the first year, and then it would go away at the end of that year. But if you love it and you want to continue to use it, then you would pay the annual fee. I think it's $1,800 for the whole year to have that access to the patient data.
Thank you, Julie.
Yeah.
Questions?
So I had a question. I understand this is patient level data. Well, what is Registry going to be using that patient level data for?
I mean, in this use case, it wouldn't really apply if there's demographic information. So what you do, if you're assigned a patient in NBS and you need to use you want to access IHI data, you have to register this patient with, that's like you have to have an access trigger. So you have to manually register this patient in one of our applications. It's called PASS, Patient Association. So you'll enter 10 key demographic identifiers: first name, last name, date of birth, address, city, state, zip, I think gender, race, and then phone number, if I didn't say that, and then a unique ID.
What I'm interested in is why are non-providers of healthcare at Registry looking at patient level data, why do they need to be able to see that rather than aggregated data?
It just depends on, I think it's the details of whatever the grant that they're utilizing for. I mean, they have a copy to our database. They are the initial organization that develops the IMPC that IHI now owns. So they've always had a copy of it for research purposes, but whatever their grant funding may be used, or, you know, the scope of that work, and they need to access, you know, it's all medical related. I can't, you know, say specifically what that might be for, but you have the ability to decline it if you know, if they contact you and say, hey, we are going to use John Smith. We have, you know, it's not as.
So my concern here again is patient safety and protecting their confidentiality. So typically, if an institution is doing research on patient level data, they have to have an investigational review board that reviews to be sure that they're protecting the people who are in the research study. So what reliance do we have that Registry is going to provide us with the report from the investigational review board?
I don't have that answer. I can get it for you.
I would need to know that. I would need to know that just for my own, because we have patients, these are our patients, and we're sharing their data outside of our institution. And so if their data is going to be used for research, we need to have IRB approval, and we need to know that it's been approved for that particular patient for that particular study. Because we have responsibility back to the patient that you don't have.
Let me ask an ignorant question here. These, I didn't think these were our patients we were entering into the system. We have patients that we're serving for case investigations, let's say. These patients are already in IHI for other.
And now they're having research done on their data.
But we are simply looking at their records so that we can do our case investigation. We're not entering any of our data in there.
We are uploading data to them.
We are, okay, so that's my question.
Yep.
It's patient, yes, the demographic information. So anytime that they have a grant funding and they would use or want to use any data that was associated to your health department, they would have to reach out and ask for permission, and they would have to provide details. Now, I don't know exactly what those details are, but they would provide you the information around what the research is for, and you have the ability to opt out and say, do not use any of our data. So there is an opt out. You would receive an email. They wouldn't just use it. They have to always obtain permission prior to using it. So if you ever register a patient manually using that demographic information, which never even goes to the IMPC, it just goes to a table. So it never makes it to our database, to that data repository. It is stored in a table. So it's highly unlikely that you would ever get an email, because that data wouldn't have made it to the data repository that they have a copy of. Then they would reach out via email with those details of the grant funding, or not the grant funding, of the grant, and then it's probably that IRB. I'm not certain on the exact wording. And then you would have the ability to say yes or no.
The other thing that we need to know is there's an adjoinder agreement, and there's a mention in the contract that there's a certain box that has to be checked on the adjoinder agreement in order for us to receive back data from the system. And how do we go about making sure that box is checked for this county?
I have a question.
The data that you receive is the data you have access to in the CDS application, all that patient data. That's the data that you'd receive, is the viewing access in CDS to view that data that you're using to complete your cases that are assigned.
So in the case of Monroe County, is that box checked that we can receive back information?
Yes.
It's not just a one-way street? Okay.
Yeah,
Thank you.
the patient, the past application associates that patient that you're researching to your health department. And that's your access trigger. It takes that data that you enter in pass, goes into the repository and does a patient match. We use that so we can go out and find all the data for that person and attach it to your user so you can log into the application, then the CDS application, and view the longitudinal health record. So that is your access. That is the data that you're receiving. The data you're providing is that demographic information that lands in a table that if Reagan Street was to ever, I just can't think of a use case where it would happen. If they were wanting to use it, they would have to contact you. It's via email, and then you would have, with the details, and you have the ability to decline them using that data. So that's the data provider, and then the data receiver is when you can actually log in and view that longitudinal record for that specific person.
Got it.
Diana, did you have a question?
Yeah, I just found the hand to raise. I'm sorry about that. My question is who's going to be responsible for managing the system, and do we actually have people that can do that? And then who's going to train them to use the system appropriately?
Okay, I'm going to ask Lori to address that.
Sure. Well, so I would think that we would be getting some initial training from the IHI, but internally in here within the health department, our disease intervention specialists would be accessing and using this system.
And do you feel that it would be helpful to have that type of information?
Oh, yes.
They have expressed that it would be extremely helpful for her.
Extremely helpful.
Okay, that's what I want to know.
Thank you. Sarah,
And can you go ahead? Sorry.
I'm sorry, did you want to answer more, Julie?
Yeah, it's just, the applications are it's accessible. They're public URLs, so they're your URLs that will be provided during the training. And then multi-factor authentication is required as a second form of authentication. So it's super easy to access as long as you have an internet access. And then if you decide to move forward, contracts are signed, and there's a project, we have to do some configuration. At the end of that, there is a training via Teams for anyone that would like to participate. And then we could always do ad hoc training if there's others that are added that need it. But the applications are super intuitive. So I think that, user adoption will be quick and easy and helpful.
Okay.
The adjoiner mentioned that we needed someone trained in CDS/SAP specifically. Is that, do you think that's required for us to provide them?
Julie, did you hear the question?
I mean, you'll CDS is the clinical data search. That's the application. You will need training for that. At least one person in the health department will need to have training for that.
And
just to understand how to maneuver.
So who pays for that training?
It's part of your project, which the state is covering. They're covering the implementation fee. That's $1,750. The grant funding is covering that. And then they're covering the full first year of service. So the date of training is day one of your contract. Because at that time of training, your users can begin using the applications in their daily workflow. So that's day one. So the implementation fee covers the setup and training. And then day one is once the training is completed, would start your first year that the state is also paying for in that in that grant funding. So, and if within the first 6 months, if your users are like, it's great, but it's not what we thought it was going to be, I don't think they'll say that, just from other feedback from other health departments. But you can terminate and say, we do not want to continue beyond the first year of service, and you would not owe anything to IHI. If you decide you love it and you want to keep it, then at the second year, you would be billed for that annual fee.
Thank you. Sarah, you had a question, and then
I have a very naive question. Do patients have the right to not be part of this and to maintain their data outside of this system? How do they actually become aware that they are going into a system that will have all of their health data. What is my right as a patient?
The onus is on the HIPAA sign off that you have with that like health facility or provider. So within those documents that you sign off on when you see a provider, it says, do not share my health data, do share my, whatever the questions may be. The onus is on the sending facilities. And then we also have an IMPC committee that governs who and who cannot access. We don't just allow anyone and everyone to have access to these applications. It's got to be an approved use case by this committee. And then, there's auditing and things that would happen in the background as well. But as far from a user standpoint, that happens at the provider facility level when you sign those HIPAA documents and things like that.
Thank you.
Thank you. Diana, did you have a question?
No, I'm fine.
Okay. I'm hoping we're in a place where we can make a decision. Okay.
I have some concerns.
Let's hear your concerns.
Well, I think that we need to have a chat with our technical services director, make sure that we have the safeguards in place for protecting the data, and to check with our cyber insurance company about this, because this agreement puts us on the hook. If there's a breach that we're responsible for, somehow we have to pay for all the notifications of IHI and others, and that's expensive. So I just want to have the director look at that and take a peek at this.
So that hasn't been, he's currently on leave. Okay, will he be back by next meeting? Can we get down to playing that on? Should we table this?
I would, yes.
I think, yeah, I was thinking,
Okay.
in view of what Dave just said, I think
view-
we should table it. Yeah,
I totally
I would move to table this until we get further clarification from our technical
internal
people. Yeah.
Just one thing, the institutional review boards are discussed in Article 6. It's in the,
Yeah, I wasn't convinced that we were going to get back information that the patient would actually be involved in order, rather than deciding for the patient whether they can have their data or not. So
As a consumer of healthcare, I'm real concerned about the breach and security of my health records. I mean, my personal records have already been hacked several times, and even my fingerprints are out there somewhere. So I am very concerned about how things are protected.
Do we need to vote?
second on the motion.
Okay, thank you. So we have a motion to table this till our next meeting, and was there something in your motion about there was more information, right?
Yeah.
Get more information?
Yes.
We have a motion, we have a second. Roll call vote.
Lee, aye.
Lisa?
Lisa, aye.
Steve?
Steve, yes.
Okay.
Yes.
Diana?
Oh, sorry. Yes.
And I'm also an aye, yes. Thank you. So we will talk about this again in April and see what the outcome is.
and to our visitor from IHI, would it be possible for us to call you with questions in the meantime?
Sure, we can do that or arrange a call. I would include my legal counsel so they can help to answer some of your very specific questions. And we can also provide any kind of technical, we're high trust certified, which is the highest level of security. So if there's anything around the data security and breaches, we can provide that information as well. Any vendors or folks that you need to talk to on your end. So yeah, definitely anything you need, just let me know.
Thank you very much for coming, Julie, and for all the
Welcome.
information. It was very helpful.
Of course, yeah, you're welcome. Thank you.
I'm sorry. Do that. Sure.
I'm kind of unconventional for just a moment, if I may. Dave, can we revisit this for one moment, please? Because I actually want to revisit my decision, my vote. I want to ask him another question before he leaves, if he's.
Are you running? Jay, go ahead. I'm not sure how we Go ahead.
So I would like to just revisit for one moment the order that you came up with. So can you just explain one more time what it's so that we're basically communicating what's happened in terms of the order for the court? We are saying this was the court order. We've made our changes that we can. And so it gives the patient, or rather the person, something to take back to the court? Is that the?
We would be filing it with the court.
Mhm. And so what does that mean sort of legally in the future? Like, tell me what that means.
Well, it just means that we're letting the court know that we've received the order, we acknowledge it, we're doing the best we can to comply with it.
Okay.
So that we're not held in contempt of court.
Okay.
And
I understand.
if anybody is involved in that case, they will receive a copy of the report and they will know that we're doing everything we can. So if they decide to initiate some kind of legal action, they would hopefully leave the county out of it.
Okay.
And this kind of describes our policy or our, it's not more than a policy, but you know.
So I would like,
The process.
I'm sorry, Steve.
No, that's all right.
So I would like to change my vote to aye. I just wanted to understand it a little better. Sorry, but it was just.
Do we do another vote?
So my roll call vote. The minute.
So we change, okay.
Sure, but I would like that
Would
to
you,
change.
would you please reflect in the minutes
Thank you.
that Lisa's vote was aye? Thank you, thank you. Okay, we're making another change to the agenda. It's been requested that we talk about the annual report now.
No, the codes.
Oh, no, the codes. You've got a point.
And Simeon can go home.
Okay, the codes.
Yes, so we have three members here, so I think that Simeon and Alyssa and Cheyenne can just talk about changes to each of the codes, and then we can take a vote on it.
Let's do that.
Let's start first. Dave, do you have the updates on anything, the codes?
Oh, I have a copy.
Oh,
So mine,
Is there ordinances?
there's some just minor wording in some of the codes, but our pool code, local pool code, we wanted to include public beach. There's a state code for that because we currently only have one public beach, Little Point, that we inspect. And we have a little more guidance in case for some reason somebody puts in a public or semi-public beach in Monroe County. There's a little more guidance for that.
okay.
So that's fairly standard thing there. We want to change the seasonal license changes from 5 months to 6 months. We have apparently a longer season than expected. So in the past, it was 5 months or less for seasonal pools, and year rounds were greater than 5 months. So now it's kind of simplifying it, 6 months. Most pools will try to get going May through maybe October because of sometimes longer season. And so just a change there, which is insignificant also. And there was also, these are the late fees, so I don't know if that can be part of what we're discussing here. So I know in the minutes, I was talking about the yearly license renewal for late fees to stop that. I don't recall when we were with David in the meetings, whether or not we wanted to include the seasonal pools. The reason I'm saying this is incentive to have a 10% late fee per month up to 6 months seems a little ridiculous as far as I'm concerned. We can easily enforce a code where a year-round pool has an extension through January, and after that, they're going to be on an expired license, and therefore we can do what we deem necessary, and we'll always work with everybody when we can. But if somebody isn't compliant, we can disclose that. We don't want to have to do that, but that gets us, we're not into picking up an extra $45 here and there. And it's just a lot of work for the front office staff also. So
That makes sense.
big. Now, whether or not the seasonal pools were included with that, because it is in our information here. The thing with seasonal pools are, we don't know when they'll open. And so that really makes it tough. Somebody may want to open in April and somebody else can't open until June, for instance. And then we have to keep track of, where we are with how many months since they've been open. Same thing, we know where the facility is, we know how to properly get them to comply.
Okay, sewage disposal, it looks like, and we already talked about pools like a lot. So we've got sewage disposal, on-site soil evaluation.
Yep, so my code changes are mostly all just fee changes. The soil report review is specifically in reference to planning department's updates to their CDO ordinance. They originally had required a septic permit for the issuance of minor subdivision platting. However, now they are changing it to just a review of a soil report, which for our purposes would essentially be like half of a septic permit. So we're asking for the chance to create a new basically review process in OpenGov with a fee of $50, where somebody just gives us a soil report in an area where they would like to place a septic system at a later date, but don't necessarily have all the information such as bedroom count and type of system and sizing requirements for a full septic permit that would require a site plan. So that is that one. And then there's also a request to change the fees for the septic installer certification or registration from $150 to $75. That's mostly because it's going from a biannual to an annual fee. So instead of it lasting for 2 years, now the registration lasts for 1 year. And it just essentially stays the same, just the changes for, because of the time frame change. And then finally, a request to create a fee amount of $350 for a biannual holding tank per operating permit. So we're required by the state now to issue holding tanks for not just repairs, but also new construction, basically when asked. However, we can also require an operating permit. So they would get a new septic permit for the installation of the holding tank along with all of the requirements. And then once that 2-year permit expires, then they would be required to have an operating permit, and we're asking for that fee to be $350. And that would be every 2 years. They would have to renew that operating permit in perpetuity until they either connect to a sewer line or connect to a septic tank.
What's the fee now?
We do not have an operating permit fee because historically Monroe County has not issued holding tank permits except under repair situations where there was no other option. However, since the state has required us to now issue holding tanks under request, as long as it meets the minimum requirement of minimum code requirements, we're expecting to have a larger portion of holding tanks operating in the county, and therefore now need a more thorough program to monitor them.
And is there a reason why the number is blank under certified soil test review? There's no number in here.
I am not sure, mostly because I did not prepare those documents, but I do have one that says $50, and that was my suggestion.
So this should be $50 on page 2 of the document that you have under sewage disposal. It should be $50.
And that's just for us to be able to have an application, review it, receive a soil report, and issue what we would call a minimum specs document, but would be rebranded as a review for soil report for minor subdivision platting.
So this is actually a change to the code and adding the fee. Is that correct? You're adding a biannual operating permit.
That's for the holding tank.
Right.
That portion is updated in chapter 365 that has been sent to the technical review panel. However, it is also under Indiana Code 16-41-25-9 and references that the county health department essentially has a leeway to create a program for an operating permit. We just hadn't done so before.
Anything else on codes that needs to be done?
Hi, I'm Melissa Delgado, I'm the senior environmentalist for foods. We're going to change the late fee for retail food establishment licensing was from 10% to 100%. Just some background, all retail establishments have to renew their license yearly, expiring February 28th. And after that, they are operating without a valid license. So we're hoping maybe this 100% fee will let people apply on time. Currently, we have about 20 establishments still not applied. And in the beginning of the month, we had 20. And that's with numerous phone calls and so we will get a list of those places so that we can work. Right now with the 10%, it does increase every month to another 10%. So next month it'll be 20, but we don't have many establishments that go past April.
Discussion, questions?
No, I would support that.
No.
It's
Food, yeah.
in a conversation I had with Simeon prior to the meeting, I suggested that if either we drop the fee or increase it drastically, to make it onerous not to pay for these permits and things on
I
time.
think it's a great idea.
So
Okay.
I agree with that.
Any other questions or discussion? We have a whole lot of things we have to talk about. Yeah.
So I don't have questions from the staff. I just think that this is pretty onerous for people who are putting in holding tanks don't necessarily have money to pay the county every 2 years a fee to continue to have their holding tank. So my thought that if we're worried about safety and groundwater, et cetera, is one, we either change the fee, or two, I would rather it be, they just put the holding tank in, so I don't think they need it checked again in 2 years. So maybe 3 or 4 years and then decrease the fee. That would be.
So what do you
Would you
think
like to
about that?
respond to that?
Yeah, so holding tanks, they are sized based on bedroom count. They have a minimum and a maximum sizing per state code. Basically, they last for a size based on sizing for bedrooms. They can fill up about more than once a month, essentially. I usually suggest when people have a failing septic system and they have to use their existing septic tank as a temporary holding tank to pump their tank, about once to twice a month minimum. And so there is the chance that more holding tanks in the county could mean that there would be more chances for those holding tanks to fill up and then discharge, which would put a more time constraint on our staff to be able to monitor those regularly. There's also the fact that they're required to have audio and visual high-level alarms at all given points. And if those go out, then there's not, and then they wouldn't know, unfortunately, that their holding tank is overflowing. And then that would also be an opportunity for a holding tank to unfortunately overflow and discharge into the environment.
It's video?
Video?
Did you say video, audio, and what are the alarms?
Audio and visual high-level alarm.
Visual, high level.
So it's supposed to be able to see and also able to hear. But if it breaks or goes out, then there's of course the chance that they could start overflowing and discharging.
Yeah, I see this as a lot more work, Lisa, than it appears. I mean, that on the surface.
And and I understand that, I just am concerned about, and I could be wrong, but typically people who are putting in the holding tanks, they may be less expensive than the finger systems or the Presby system, and that they may not be able to afford that fee is my concern. So what
Well, they're also going to have to, I apologize for cutting you off. I didn't to. But they're also going to have to pump it out regularly. Like I said, once or twice a month, that's a fee of $150 to $250. So if somebody's already planning to install a holding tank and pump it at basically a sewage fee of, $100 to $300 a month, then comparatively for the ratio, I did not see a problem with the $350 once every 2 years for our staff's work.
As far as, do most people who get holding tanks do it because they flunk their perk test or whatever?
So far, the holding tank, since the institution of the state code, so far the holding tank applications that I have received have been completely by request. And one even had a soil report that would have asked them been able to place a septic field, but they chose not to.
So you think it's probably money, it's cheaper than, like she said,
cheaper, I
digging
believe.
fingers and all that stuff, or like why do people have them?
Mostly because they don't want to place a septic field, from my understanding. But again, that's kind of a personal thing. When it comes to citizen requests like that, I usually don't ask much more questions other than what it is they want to do.
Well, historically, we just haven't really issued permits for those holding tanks. Is that correct?
Yes,
In this county?
yes.
We did not allow that. But the state law changed to require us to allow.
Yeah.
Yes.
Wow. That the state law changed, also requiring one soil scientist. And then they made it so just about anybody can do anything, in my opinion.
Yeah, so previously, since I've been here since 2019, we had only issued one holding tank permit, and that was because there was no other option. There was nothing that it could be placed at any given point in time. However, since that state code has changed and we are required to allow holding tanks, it is all of the requests that I have received have been because they wanted to go with that option, not because they had to.
Maybe any people flunk their fault. I guess you haven't had it long enough to see if.
I haven't had anyone fail a soil test in that and then decide to go with a holding tank.
But how about an overflow situation like we're looking for going forward? Overflows, what's the holding tank?
The instance that where I had to, for the holding tank for permit that we issued while I was here at least, I will say that there was a continuous issue of that holding tank overflowing, and there was, I don't have a number count off the top of my head, but it was multiple inspections requiring the homeowners to pump it multiple times over the course of several months. Also, as far as historical holding tanks in the county, when I have found them, they have often been in some sort of failure or some sort of situation where the tank is a black water tank where it's only connected to the toilet, and then they have a gray water line that would be considered now a direct sewage discharge that we would have to reroute into the holding tank.
So it is expensive for your department to monitor these things.
It does take some time and paperwork and multiple inspections a lot of times.
Thank you. We really need to move it, guys. Can I have a motion on this?
I would move that we accept the proposal as it's written.
Second?
Second.
Second? Okay, roll call vote. Lee?
Aye.
Lisa?
So I agree with everything except the one, if we're not gonna change it, then I just vote nay.
Okay, Steve?
Yes.
Okay,
Okay, yes.
Diana?
Yes.
And I am also a yes. Thank you. Thank you, thank you, thank you. Sorry, I really want, we have got to have enough time to talk about the board priorities and the council and commissioner open house. Like, we absolutely have to do this.
Okay.
So let's try to speed through so we can let these nice people who are here to give us the public health clinic updates go home and maybe have some dinner.
I'm Vicki Vaught. I'm one of the nurses at the public health clinic. I'm the vaccine coordinator. Lindsay is on vacation, so I'm presenting in her place. I'll try to go this real quick. Our recent outreaches, we've done hypertension screenings at Providence Place, Banneker Center, Healing Hands, Pantry 279. And we've also done diabetes, cholesterol, hypertension at First Christian Church, diabetes and hypertension at Camp Hunt for Wheeler, And we also went twice out to Seven Oaks School to do hand washing, hygiene, and dental hygiene lessons with their students as well. We did a total since the last meeting of 71 hypertension screenings, gave out 17 blood pressure cuffs for people from home monitoring who were found to have hypertension. Our future outreaches that we have coming up, the Faith and Wellness Summit at Sherwood Oaks, and you all should have gotten a copy of the flyer about that. We will also be going and doing diabetes screening and education at Providence Place on April 17th. We'll be doing the Health Palooza at South High School for HPV vaccination and education on the 24th. We'll be going to Second Baptist for Wellness on April 26th and back to Healing Hands for more hypertension screenings on April 28th. And we will be doing the 50th Plus Expo at Spitchard Park on May 7th. Some lead updates. We have 8 open investigations with 5 confirmed and 3 suspect. They did a home visit last in February, none currently scheduled. Communicable disease, we have no current threats that we are aware of. We are monitoring respiratory illnesses such as H5N1 and measles. We did have a preparedness meeting on the 13th of this month. And IDOH now will be bringing a mobile unit with MMR down to do a clinic on March 31st from 1:30 to 5:30 at Monroe County Library Southwest Branch. And I know you said you were going to be putting that out on social to advertise that. I think they plan to bring like 100 doses and said that they would come back if the need outpaced what we were posting there. We have less than 5 active TB cases with 20 LTBI cases being managed. Immunization updates, we plan for school clinics starting April 2nd, continuing through May 17th, including 19 schools for MCCSC and RBV, depending on getting orders in. Those are planned. And our whole staff attended the Public Health Day on the 12th in Indianapolis for representation and networking. And we are currently fully staffed, cross-training all nursing roles, and we do have some new office hour changes. We'll be starting April 1st. Monday will be open from 7:30 to 5:30 to help patients that needed to come in before school and work and after school and work to give some more time for them. And then Tuesday, Thursday, we'll continue from 8 to 4:30 and continue our second Saturday of the month from 8 to 11. Okay. Any questions?
Good job. We appreciate you coming.
Say a quick comment. I'll
Questions? No, discussion. Yes.
So, I noticed that that clinic's supposed to serve as an overflow for IU Health offices when they're full.
Our clinic?
Yes.
Yeah, so we're open to the public. So a lot of people will come to us for their immunizations. It relieves a lot of the
Did
pressure.
IU Health call you and say, we're booked up, will you please take care of these 5 people? Or
We haven't had that occur that I am aware of. They, especially the PD offices, know that we're available.
Right.
And can refer their patients onto us. And I know like through flu and COVID, they were sending a lot of people to us, but they haven't like called us specifically as far as I know. But we do coordinate with them to let them know, like, what we have in stock, what we, especially.
So how would you be if that happened? How would you be if that happened? If every day you got 5 or 10 overflows from IU
I
Health?
think we could handle that. Yeah. We run 2 vaccinator schedules, going through the whole day with our staff.
Because most of the providers at IU Health aren't aware of that option for their patients.
Yeah. So, I mean,
They just tell them to come back 2 weeks from now.
I know that Health Nets refers a lot of patients to us as well.
Right.
For that.
Good.
Any other questions?
I'll just say our health clinic works.
Yeah, well, yeah.
Yeah.
So officially the clinic rocks. Thank you so much for coming. We really appreciate it.
I can be super fast. I can cut it way down.
And poor Kay, your husband's probably on his way.
Let's see. March 28th, so next Friday, the department will be opening late at 10 a.m. So this has been posted online. This is due to an all-department meeting that we will be having at the courthouse. I was going to touch on the mobile unit, but she already did that.
Do you want any of us there for that? The all department meeting? Are you going? You're going.
What is it?
All department meeting.
Oh, I see.
So certainly welcome if you'd like. You're welcome. Woo. Okay, bring your cell phone if you do. You won't win a prize. Let's see, so County Council did issue a resolution on March 11th, which is temporarily suspending Personnel Administration Committee and job review requests. So currently, no requests for new positions, reclassifications, or job description amendments that would result in an increased cost can be submitted. This is supposed to expire at the end of the year, so December 31st, unless they decide to eliminate that prior to that date.
Is this a result of the county budget, the several $1 million error?
I am not sure what it is a result of.
And do they consider, for example, with the STD grant, if we have a grant funding position in the state, is that considered exempt from this because the state is paying for that position?
I have not received an answer to that question yet.
Okay, important question to get an answer to. Thank you.
The department, so Bryce conducted an emergency notification fall down drill internally on March 19th. This was just to assess our internal readiness to respond and communicate effectively in the event of a public health emergency. So we did have 100% compliance, even including employees who were out in the field working. So pretty immediate responses. So that went well. He will still be developing an after action report, and that can be shared at a later date, which will also just comply with one of his grant requirements. There is discussion of reducing the Health First Indiana budget to 100 million. That's where it currently sits at this time, which would then be divided among counties opting in. The state is encouraging that counties submit success stories just to promote the work that's been done and to reach out and really just promote how we're using the funds. I have submitted few different success stories about our internal programs, which have been shared online and with state meetings. Let's see. The Indiana Department of Health regional teams are setting up meetings with all local health administrators to check on our key performance indicators and our progress with that and for service data. We are still interviewing candidates for the Director of Public Health Preparedness. This position will be trained in preparedness, available to respond 24/7 and serve in that backup capacities to have 2 positions.
And you're being assisted in those interviews by?
So Dr.
Ryder. Thank you.
And the Health Services Director job description went to WIS. The classification remained the same. That will go to in April because that was an item that was already submitted, but we'll find out at that April meeting, I guess, kind of where the position will go from there. Let's see. And then a letter of intent was sent to accept the immunization grant funding. COVID supplemental funds have gone away. Reductions are expected, but we don't have final award numbers at this time.
Can I just piggyback on one thing I've already said, which was at the INSACO meeting today, one of the analyzers of the HPI data that was presented to our legislature only looked at 3 of the areas that our funding has gone to, and it's already proven in a very conservative manner that there's a 200% return on investment in the first 8 months of HPI. So I'd be happy if you guys have not seen the report that was issued to send it to all the board members. It is out there and it's very impressive. And again, it's very conservative and the analysis has been stopped by our legislature.
I'm really concerned about our funding, and from what it sounds like, the discussion in Augusta, I'm not in Maine anymore.
Yes.
Discussion,
Up in Indy.
thank you. The discussion up in Indy is that, well, we don't need all this money and it's not getting any return on investment yet. Well, it doesn't work that like,
Well,
can
they
somebody
already
please
proved
tell them it doesn't work that way with health?
Not only have they already proven that it works,
And
but the legislators don't even know what's in the report. They did not read it. They're unaware. And so
is there something more that we could or should be doing to educate whoever needs to be educated?
Well,
again, on why we need this money. I mean, the Governor's Public Health Commission just did it a couple of years ago. They just did this, and it sounds like it all has to be
well, our center
done
people,
again. And
our center
how can we
senator,
plan?
our Senate, our,
We've got wonderful people. Yeah,
well,
there's no,
some of them. I mean, but we have 4 sections that we've been divided into. So contacting all of the people who represent us with the real data and saying, please read this and understand, even in this tiny bit of time, that there is this huge return on investment. It should make a difference, but we need to get lots of people doing that.
and it needs
Because
to be a one-pager. We cannot give them a 40-page report. It needs to
No.
be one page, ideally bullet points, you know, here's what's been accomplished. Here's why we still need
funding.
the money,
Well,
because we can't plan for funding that may go away tomorrow, which means it will be a self-fulfilling prophecy, you
And-
know?
and
If we
the-
can't get these things off the ground,
The only things that they looked at were blood pressure, and falls in people over 65 and prenatal care. Those were the only
But
areas that they said.
it doesn't matter. They did a really good job.
They did a great
They did a really good job.
And they've been
And-
stopped from doing any more.
So their session is almost finished. It'll be finished by end of
May.
April. Yeah, early May. So your best bet to make an impact is to contact Shelley Yoder or Dave Hall. And then from there, be prepared for next year's session because they're finished
Makes sense.
really quickly.
Makes sense. Thank you. And I also have concern about our inability to hire folks through the end of the year.
I think the county government is tightening the belt for whatever reason, and they're concerned about state funds, or federal funds also and state funds, and so I don't think that issue is going to go away anytime soon.
Just in an very uncertain
I just feel like
environment.
we're being cut off at the knees, and
Well, I think
then we're gonna be.
we need to insulate ourselves, and that's what I drew that up there on purpose. That thing I drew up on the whiteboard is a way that the Marion County is organized. They have something called the Indiana Health and Hospital Association, which runs the public health department and an ambulance service and Eskenazi and a foundation, which they fund separately. And that money is theirs, it's not the state's money or the county's money. It's their money, which means they can't be cut off at the knees every time the budget gets slashed because they have a buffer. So we should consider some kind of a structure like that.
But that's a discussion for another.
It is.
Yeah.
I just wanted to bring it up.
Thank you. Any other comments or discussion about Lori's report? Okay, thank you.
Thank you, Lori.
Thank you. Okay, quickly, can we do the mobile unit?
Yes, I don't think that we really need to elaborate that too much. I think this is really just touching base. So this came up shortly, I think, after we had our first medical student, so discussion around this. And so remembering that we've had a couple different conversations about donations, using COVID reimbursement funds. What would that actually look like for our department? With looking at different units and what we would need and how the department would use it. So just to be able to kind of get an understanding about the direction to go from here. Staff have been asking about this and they have put together ideas of how they would be using the unit. But I think it would be helpful to know whether Linnea was really helpful and going through some different units and collecting that information and whether we should continue gathering different styles and units to be able, for the board to be able to review.
Did you know that there is a national website for mobile testing units? Okay. I don't need to
And
know that.
it also seems like part of the decision would be based on how large a unit is needed. Whether you need one room or two or whatever, because size matters.
So is this document in our packet then their ideas?
Yes.
So if you want to take a look at their ideas for the mobile unit, it's on this one. And it looks like, you know, we don't lack for uses, right? So what do you need from us on that?
I think just some direction about the information. So if there's specific information, what would you like to start seeing presented in the next packet so we can start gathering that?
I just like to make sure it's aligned with our community health needs assessment so that it's satisfying those and health first and the things that we have to do.
I think many of the, if you just glance at this, I think many of the items on here are represented. So I think we could massage it.
Yep.
For sure.
I had a phone call about 3 or 4 months ago. And it was from someone I knew, and they were willing to make a donation towards the mobile unit. I think my enthusiasm was maybe I didn't express it. I expressed my enthusiasm for the idea, but I think my own idea was that they were considering a larger donation than I think they anticipated, although it would be a sizable one. But at one time I thought maybe they were talking about financing a large portion of this, which they could do. And, you know, I have followed up. I wasn't sure at the time what the process was for direct donations to the department, and it actually is just within a contract with the commissioners. And it can be done anonymously.
Dave knows. I'm pretty right here.
Yeah, well, that's okay. I mean, I talked to, I know how it's done now.
Okay, oh, okay.
Yeah, and I think it was.
Let's not ask any questions for time's sake that we already know the answer to.
Oh, my gosh.
Okay, anything else on the mobile unit? Okay, I want to hear from Lisa about what the proposals are for us to consider for our board priorities of interventions or programs that we could put into place that would make a difference.
Okay, so we met with Lori and Dr. McKinley and I. And out of that, we came up with two different things. One, chronic disease management seems to be something that's really important in trying to impact blood pressure, stroke risk, cardiovascular risk, obesity. And kind of our concept that came out of that was things that we need to start working on, I guess, and thinking about now, which is as we have partners, we need in managing that, we need sort of massive amounts of data that are not biased in any way from any particular. So it's an aggregate of data that we sort of get ourselves, if that makes sense. So if we have partners, those contracts, in the contracts, it needs to be written that, you know, here's the data that we expect from exact data points that we expect from them in a way that's usable and on a larger scale. So trying to marry, you know, 10 patients or 100 patients got their blood pressures checked, you know, how are we impacting actual stroke risk or MI risk in our community? And, you know, of course, that it is kind of attached also to our largest contract, which is with IU, in asking for data so that we can show the public and our constituents that we're providing, we're using their taxpayer dollars to impact, you know, my grandmother didn't die because she didn't have a stroke and those kinds of things. So, but I think, so that was priority number one. And I think we also need to look at that as Lee said, in this broader picture, because we're the drivers of healthcare for the community. And the second issue, which is as Dr. McKinley said, top of mind, I'd like him to talk about it, is that our statistics actually aren't the greatest for measles vaccination, actually. And he has data, and I'd like him to talk about that, because we do not want to be, we don't want to be Texas. I mean, and if if we really aren't vaccinating our people and our kids, you know, then we have to change that. And then that's a mindset change, I think, publicly. People are afraid. So Lee, I'd like you to talk about that.
Yeah.
So I want to point out, you do have, you
You
have a one-page sheet in your
got it.
packet
Read.
called measles summary. So I would love to just
Yeah, I won't
hit
read
the
it, but
highlights.
I
Yeah.
won't- Yeah, I did put sources at the bottom, so if you want to look this up yourself and verify. I just looked it up this afternoon to re-verify, the numbers keep changing, obviously, but vaccination for all diseases has gone down since COVID because people are just scared and they don't know what to do. But it turns out in Indiana, we have an opportunity because only about 2% of the refusals are non-medical. Most of the refusals have a medical basis, a reason why you can't give them the vaccine. They've got leukemia, they're on chemo, there's some reason the kid can't get it. And so we have an opportunity to get up to 98.5%, which would far exceed the goal, which is 95%. And the last 5 years I tracked it in this county, it's been dropping down 83, 82, 81, now it's down to 74%. And when the goal is to be at 95%. So we're well below that. And it's not all children. In Texas and New Mexico, some of the, like 22% of the people were over 18. So we may have people who are adults who still need vaccination. It's kind of shouldn't just focus on kids.
Right.
The school system does a pretty good job of requiring that to go to school. So anyway, I published all that, and so I think we need to have actual agreements with people, and like Lisa was saying, where the data drives whether, number one, whether they're making improvements, and number two, do we give them another contract next year? Because what happens is they, like IU will come back or whoever will come back and say, well, this year it's going to be 400,000 rather than 300,000 for the same contract. And then we need to be able to say, but your data shows that you didn't improve blood pressure or diabetes or blah, blah. And so if your outcomes data are poor, maybe we won't renew it, or maybe we won't renew it with as much money. So I think we need to have some teeth in our contracts so that we can defend ourselves to the public and say, we're spending your money wisely. And we have data to show that we're actually impacting health in this county. And it's hard to have those kind of conversations because we're all in the same community, but we need to make them responsible to us. And we need the data to do that.
Okay, I want to thank you. I want to
Yep.
get us back on track with what I understood Lisa's December idea.
So right now what we came up with were two, and we're happy to add on a third. So chronic disease management and even though it's, the tangible quick thing is to have, the clinic, here we have the data from 2024 and it's truly abysmal. I mean, there were 8 blood pressures recorded for all of 2024. This is ridiculous. But besides that, I mean, that's kind of a day-to-day thing. But I think just thinking on a larger scale to try to, set the tone for the next even 3 years. So that and discussing having a campaign with people we already have in place to decrease fear of vaccines. I feel like those are things that are kind of immediate and definitely things we need. And so so if you all want to choose a third, I think it would be helpful to have a kind of a public statement from us saying, this is our ideas of goals for us for 2025.
Do these both align with the community health needs assessment?
Except for
Priorities.
it prioritizes access and primary care and opioid use disorder.
Okay. Access and primary care would get it. And I always, in any discussion of health issues, I always have an issue when a problem is observed, which you guys have definitely observed a problem, and you have suggested a solution, But in the middle, we don't have enough data about what is actually causing the problem. So you brought up it's fear of vaccine. We don't know that. We don't know why people are not getting their children vaccinated.
The state has that
we
data.
don't-
We don't have it.
We don't know why.
We don't have that data. The state has it. Indiana State has that data.
They undertook a survey asking why people were not getting vaccinated, and that exists and is published.
It is in all states that I've looked at, except for Indiana. Texas had a 20% decline rate.
Those are decline rates. That's not what I'm saying.
Part of it was
What
medical.
I'm saying is, while we're waiting, I mean, we sort of don't, it's a kind of we're trying to avoid a public health crisis, which is a death or a death
I get it.
from
I get
MMR.
it.
So great data, and we need data, but we sort of don't have time to, I think a public campaign that's pretty simple and saying, you know, here's the risk of getting measles, you know, here's why it's safe, here's why you shouldn't get it, and just giving science. I mean, it's not a judgmental thing. It's just, hey, you know, we're trying to promote vaccines.
Okay.
Yeah, maybe if we had three health, if we had three health objectives based on the first two that we definitely have. And we want to publicize that this is for Monroe County, and, you know, there is a possibility that we could get someone like Boris Ladwig to write an article about a positive article about what the health department is doing to address things that we see are strategic needs in our county. And that would be one way. Obviously, there are a lot of people who don't read the paper, so it's very limited.
But instead of always reacting to an epidemic, why don't we invent one?
Well,
Yeah.
it sounds like number 2 is probably, we're aiming for herd immunity.
Right.
And trying to explain to people what, you know, be one of the herd, you know, let's all be herd, but also giving people a chance to be herd if they are anti-vax.
Oh, I
Well,
like that. Be part of the herd, only HEARD.
Exactly. So, but giving those people who don't want to be part of that to actually be heard. And so we can begin to gather what Aurora's talking about in terms of why aren't they vaccinating?
And I didn't even get to finish that thought.
Okay.
Thank you. But all I'm saying is, if you craft an intervention based on knowledge you don't have,
Right.
as far as we know,
Doesn't
people
work.
aren't getting vaccinated because it's an access issue. They want to get, they're not afraid. They want to get vaccinated. It's an access
Should we
issue.
just do social
And
media
If we've created,
posts?
you know, a marketing campaign about fear, but they're like, I'm not afraid.
Well, the proposal was not to give shots. The proposal
Yeah.
was to have an agreement with other people who give the shots so that they share data, that data that you need, obtain data on why people are not taking them, and publicize how our rates are falling and how close we are to the Texas numbers. I mean, what's wrong with that? That's just telling them what we know.
Yeah.
That data is known, it's published, it's on our website.
And,
You know,
and they need to know that measles isn't just a rash. You know, that this could be life-threatening to your child and to your whole family.
So
I would,
we have two great, ideas. I think both ideas are great.
Yeah,
I don't think we need a third. Does anybody think we need a third idea?
let's do something.
Well, because threes,
three would really be better.
things come in threes, you know, it's like, you know, we got this, and this.
So is it about for all of you to like think about it for a month of like, what else? do
I'm
we
sorry,
want?
I'm just now noticing Diana has had her hand up.
Oh,
Okay.
Sorry.
Green,
Question? Comment? You're muted.
do you have a third?
I didn't realize I had my hand up. Where is it?
Oh, well, never mind.
You don't even have to, you don't even really have to hold up your hand.
You have to go,
Just
yeah.
jump in.
You have to go press the hand thing again, and then it'll go down.
Reactions.
Okay, sorry, never mind. I thought she had her hand up.
But I just didn't know if you all want to think about what you would want as a third
So
to supplement this.
We don't have to.
I think what we
I think
do
these are two great ideas.
is we roll with the two for now,
Mhm.
and then we, by next meeting, come up with our third, and then maybe we can get Boris to write something
I
for
mean,
it.
I'd be happy to call him. I called him,
Miss them?
I talked to him, not that actually that long ago.
So,
We're still on cordial terms.
So
I'm
Lisa,
holding
what you
against him.
pointed to there where you said they didn't do blood pressures, what is that from? Is that
this is
from Public
Monroe
Health
County
Agency?
Public Health Services, the Public Health Clinic, the reports for 2024.
Okay. So that is great data because we could absolutely impact those folks and we could show a huge increase.
Sure.
And I'm sure the literature has data on how many strokes can be prevented through blood pressure screenings, and all we need to do is apply that to that.
But
So-
IU needs to fix these numbers.
But that means that as I said before, that everyone who comes through their clinic, which there's a large number of patients coming through the clinic, everybody needs a blood pressure. It's really simple. They need a
Well, I
blood,
agree.
easily a blood pressure.
Yeah.
And they probably, based on whatever, could offer A1Cs so we can see who's diabetic, et cetera.
You know, based on our dealings with them, I think they'd be happy to do it if we just asked.
Well, they
You know,
did
I think
ask.
we should invite Amy to our next meeting and kind of talk about it with her.
And the other thing that
Let
we
her
need
know.
to consider when you're looking at the data,
Who's like more of our liaison now, so they kind of changed.
when you look at the data, are you also looking at infants that they're seeing in the clinic?
Well, I mean, I have no idea. All I'm
No
just
way.
saying is the adults who come to the clinic or, you know, kids 10 and up or
We
whatever.
need that breakdown then, if
Right.
you want to look at that, because if you're seeing WIC kids, then,
Well, sure,
Yeah.
that's different.
yeah,
but-
exactly. But I'm just saying your data may be skewed in some way that we're not really understanding.
So I want to kind of tie this to our other item, council and commissioner open house, and we're really going to need to adjourn. Because the two are kind of tied together, because I think our thinking was we're going to hopefully, unless you guys want to change the date, we were aiming for April 25th, which was a date Lori gave me that would be good for her folks. I think it went out on an email. I think you all said it was fine with you. So if we have the open house, then the idea was to have the commissioners and the council come through, walk through the departments like we did when we toured public health nursing, walk through, employees would say, this is what we do, you know, this is how we do it. And then we'd meet in this room, we'd let the employees go home at 4, and we meet in this room and we would present to them, here are our priorities, either blood pressure, or measles, let's say. Here's what we're going to focus on, here's why, here's what we hope to accomplish. So that they understood what, you know, what we were going to do, and they had a chance to ask questions
And why it matters.
and why it matters. But the reason why I said there, if we don't make a decision on that, we can't present it to them in April. We're going to have one more meeting in April before the April 25th open house. So our April meeting is before
Okay.
that. Could we aim to make a decision at the April meeting so that we have something to present to them? And could you guys, would you mind between now and then fleshing it out a little more? Because
So measles
Like-
is out. We picked.
I like
because it
both.
was, because it was
No.
a topical thing. It was something that's
exactly,
happening.
I like them both, but do you guys, do you feel able to vote on measles or chronic disease management right now? I would love it if we could.
I think it's, at least what I'm hearing is that it's not just measles, it's vaccination.
Vaccination.
Yeah.
It's,
In general.
Well, we could bill it as measles because everybody's interested in measles, but yeah, vaccinations for sure. And I also want to say, I'm glad somebody pointed out, it's not just babies. There are a whole lot of kids whose parents were anti-vaxxers and didn't get them vaccinated. And those kids are now 18, 19,
Yeah.
20. And I
they're-
know a couple of them and they're like, I'm going to go get vaccinated. This is ridiculous. So to the extent that we can
Yeah.
get those adolescents and young adults in the door too. Okay, so how should we just, do you want a show of hands? chronic disease management or measles or do,
I'll just make a motion that we set 2 of our 3 goals as chronic disease management and increasing education about measles and vaccinations.
Second.
so you want to do them both?
I do.
You want to do them both?
Mhm.
Okay. Okay, thank you. Okay, roll call.
Lisa, aye.
Steve, aye.
Okay, yes.
Diana?
Aye.
I'll vote yes too. All right, cool.
What time of the day is it?
Yeah, what time is it again?
I think we said we were gonna do it at 3
3.
because the employees will still be here till 4.
And what day?
So that
Yeah.
on April 25th. So the 3 to 4 times that would be when the commissioners and council come through, meet the staff, ask questions. And then at 4 o'clock, we let them go home. We come in here, there's some type of refreshments. And we do like a dog and pony show. We present maybe 2 slides only on the community health needs assessment priorities. And then we present, the vaccinations and the chronic disease management, what we hope to accomplish.
Okay.
Can I
That sound like a
take, can I
plan?
take 30 seconds for a little point of interest or something we overlooked in the beginning?
Oh,
We overlooked welcoming our brand new board member, Diana Neal, first board meeting. So welcome.
Thank you.
welcome. Glad you're here. I hope, will you be with us in the
Yeah.
flesh in
Yeah.
April?
Yes.
Okay, good. Good, good,
Look
good.
forward
We
to
will
that.
see you then.
Okay.
So sorry about that. There were a lot of people in this room.
Yeah, there were a lot.
Wow, you didn't see, there were a lot of people in this
You
room.
didn't do anything wrong. I just wanted to make sure.
Well, thank you.
Yeah.
And Lori also wants us to vote on the annual report, so we have one more item of business before we can get out of here.
I have 2 questions.
But
Okay,
I have a couple of questions and they're just in relationship to our last meeting. The vitamins, we talked about it. We said call somebody and where
I
are
did.
we on
So
that?
I called and got a list of what is suggested by ACOG and I sent it to her.
Yes, so in the process of working on.
Still yet working on it? Okay. And my other one was Dr. Sarah asked that HealthNet be invited to our next board meeting, and that would have been today. Are we still working on that or are they
That was
coming?
Limelight, and she couldn't at this meeting, but she is
She
gonna
will
work
in
on
the
coming
future.
into a future one.
That was the only thing I had.
thanks for keeping us honest. I appreciate it.
I move we accept the annual report 2020.
I'll second that.
Discussion? Okay. Roll call. Lee,
Aye.
Lisa,
Lisa, aye.
Hi,
Steve,
Steve.
Kay,
Okay, yes.
Diana,
Yes.
and I also vote yes. Does anybody want to move? Oh, board comments? Board member and health officer comments. Do you know I added you
Thank you, that's very
to
kind.
the comments here? Anything we haven't covered, board member and health officer comments?
I had to sign a form and I was out of town. Did that get signed? I received DocuSign and I went by, it was for your contract.
Oh, is that what?
Yeah. What, did all that get signed?
As far as I know, yes, yeah.
Nobody ever got back, so I don't know,
I
but
should get it.
I filled it out.
Finally did. Oh, well, then it's all right.
Right. Then I guess your signature went through, okay.
February, I got paid for January.
Yeah.
Well, then, yeah, everybody okay? I was concerned.
I do have a question. There was some issue with your Medicare.
Medicaid numbers, we are still waiting. It's been, it's now 3 weeks, I guess. It's close to 3 weeks. And supposedly Lori said today that they were supposed to be reviewing it. Well, all day long, they supposedly are reviewing it, but when I came in here at 4 o'clock, it still was under review. I was like, I guess they don't know how to
It
read.
takes a long time to review you.
I know, and
It's that background check.
That's right.
Yeah, I was gonna say, it probably is. They
probably
got
heard me.
they got your number, girl.
Yeah.
Okay, does anybody want to make a motion to adjourn?
I will. I can't. I'm
You
sorry.
can't.
I will.
Okay,
second.
we have a motion and a second.
All right.
I adjourn.
Aye.
Thanks.
Thank you. We are adjourned. Thank
Thanks,
you very
Diana.